Hello, and welcome to this discussion-based podcast on hypertension. I'm Rashmi Patel.
And I'm Ed Wallet.
And in this podcast, we're going to talk about the definition, classification of hypertension, and when and how you would treat it. So, what is hypertension? Well, this is a rather abstract definition, a blood pressure at which the benefit of treatment outweighs the risk. What does that actually mean? Well, that's looking at things statistically. Hypertension in itself is often asymptomatic. The patient won't know that they have it, and often they'll wonder why the doctor's giving them so many tablets to try and treat their blood pressure. But of course, the key here is that in the long term, hypertension greatly increases your risk of lots of chronic diseases such as heart disease or stroke. So that's why it's important to treat it. And the key figure is 140/90. As the blood pressure, you want to try and keep the blood pressure below around that kind of level.
Yeah, we're going to talk a little bit more later about how you can slightly modify your definitions and your decision to treat blood pressures. But that's a basic figure just to remember to start off with. Okay, so how does one classify hypertension? Okay, so essentially, most hypertension is idiopathic. And it's called primary hypertension. This accounts for about 95% of cases seen, and it's also known as essential hypertension. However, it's important to be aware of some secondary causes of hypertension, and this is particularly important in those patients who present young with very high blood pressures. Now, the most important things to remember, which I think are renal disease and endocrine disease. Under endocrine disease, you can have lots of different conditions, and the most important ones to remember are Cushing's syndrome, Conn syndrome, presence of noradrenaline secreting tumours, which are called pheochromocytomas, and hyperthyroidism. Also be aware, however, that pregnancy is also associated with hypertension, particularly in a condition known as preeclampsia, and also certain drugs can induce hypertension, particularly steroids.
And actually, it's interesting you mentioned drugs, Ed, because of course often, you find people presenting in the hospital systolic of 200 is that they're not actually taking their antihypertensives. So
exactly.
Always check to see if the patient is actually taking the prescribed blood pressure tablets, because that might be the reason why they're hypertensive.
Exactly. So if you wanted to investigate somebody for the presence of secondary hypertension, so say a young patient of the age of 30 who comes to a clinic with a very high blood pressure, you want to think about renal disease and endocrine disease and have some approach to diagnosis. So under renal disease, you want to look at the urine, particularly the presence of proteinuria and hematuria, which together or indeed in isolation can suggest the presence of a problem with the kidneys. You also want to do basic blood tests, particularly urea and electrolytes, because you want to look for evidence of renal impairment. So say, for example, a raised creatinine. And then finally, you might want to consider doing some imaging techniques, particularly renal ultrasound that can show both the size of the kidneys and show if they're in the correct location. Under endocrine disease, as I mentioned, you want to think about Cushing's disease, Conn syndrome, and pheochromocytomas. Under Cushing's disease and Conn syndrome, you may see a characteristic electrolyte derangement. This is the presence of hypokalemia and hypernatremia. So that polarized picture between potassium and sodium is quite characteristic for these particular conditions where there's an excess of glucocorticoids. In terms of actually diagnosing them, Cushing's disease, or what should actually be referred to as Cushing's syndrome, because Cushing's disease actually refers to a pituitary adenoma secreting steroids, while Cushing's syndrome is just the presence of large amounts of steroids, can be diagnosed using urinary-free cortisol. Conn syndrome, on the other hand, which tends to be an adenoma, small tumour that secretes aldosterone, can be diagnosed on the basis of a raised plasma aldosterone and a reduced plasma renin. Finally, pheochromocytomas, that's either benign or malignant tumours of the adrenals or extraadrenal tissues, can be diagnosed using urinary VMA, which has to be actually measured 3 times before the diagnosis can be made.
Okay, now coming back to what are the risks of hypertension. Well, as I mentioned before, the vast majority of patients with a high blood pressure are asymptomatic, and they won't know that they are hypertensive until you actually check their blood pressure. And the important consequences of untreated hypertension can be broken down into any form of atheromatous disease, and that can be affecting the heart, causing angina or a myocardial infarction, or affecting the limbs, causing peripheral vascular disease, or affecting the brain, causing thrombotic or ischemic stroke. And I think this is absolutely key because atherosclerotic disease is probably one of the leading causes of morbidity and mortality. Other important consequences include cerebral hemorrhage as a result of high blood pressure, eye disease, and kidney disease as well.
Yeah, chronic renal failure, one of the most important causes of chronic renal failure in the Western world is hypertension, uncontrolled hypertension. Right.
And now we were talking before about what blood pressure you'd aim to treat. I think I would say anyone with a systolic over 160, diastolic over 100, you want to treat them.
But the important thing here is that often you'll see patients with a blood pressure like this, but you don't immediately start treating them. Don't you? You need to do serial measurements.
That's right, not a one-off. And ideally, in the ideal world, you'd actually want to have ambulatory monitoring to see 24 hours.
Yeah.
However, in between that, 140 and 160 and 90 and 100, you may also want to treat depending on the patient's risk.
Okay, and what are those important additional risks that make you treat at that lower level? So, first of all, you have cardiovascular 10-year risk greater than 20%. And that's done by, well, actually, we're going to talk about that in a minute, but that's done by looking at some basic tables that take into account other risk factors for the development of cardiovascular disease and then come up with a cumulative risk. You can also do it based upon the existence of additional vascular disease. So that could be heart disease or peripheral vascular disease. And then finally, if there's any evidence of target organ damage, such as retinopathy or problems with the kidneys, say renal failure, then also you'd want to treat hypertension at a much lower level. So that's your 140 over 90.
That's right. Now, how do you actually work out a patient's cardiovascular risk? Well, I'm sure many of you will have seen these charts in the back of the BNF. These probably the only part of the BNF which is actually in colour, the rest of it in boring black and white. And these charts illustrate a patient's cardiovascular risk depending on several factors, whether they're male or female, whether they are a smoker or non-smoker, and then their cholesterol and systolic blood pressure. So with that information, you can then have a look at the chart, the specific chart, depending on the patient's age, whether they're male or female, that smoker or non-smoker, and then take a look at the systolic blood pressure and then the ratio of the total cholesterol to HDL cholesterol in order to work out their cardiovascular risk. The important point to make here is that these charts are for use in primary prevention only. So if a patient is, for example, diabetic, you wouldn't use these charts, or if they've already had some form of ischemic heart disease, some kind of myocardial infarction or event, then these charts wouldn't be applicable because then you're looking at secondary prevention.
And a much higher risk.
That's right, they're already at risk.
Okay, as always, management of hypertension can be broken up into conservative, medical, and indeed sometimes surgical.
Right.
There are some new surgical techniques that can be used to control hypertension, which include basic stimulation of the carotid sinus, but that's a bit beyond the scope of this podcast. So basically, under conservative management, what we're thinking about is modifying risk factors. And the important ones here are to encourage patients to lose weight. This is incredibly difficult, but some patients can be encouraged to do this by modifying their diet and by increasing the amount of exercise that they do.
That's right. Very, very simple.
Yeah. You want to encourage them to stop smoking, and you also want to give them advice about reducing alcohol intake. Finally, it's been shown, although this is often debated, that the presence of a low-salt diet may be important in controlling hypertension. If these things are not effective, then you would wish to consider medical therapy, so drug-based therapy. And this is based around the British Heart Society's guidelines. These are basically a set of guidelines that, dependent on the patient's age and ethnicity, guide you to which particular antihypertensive to start initially. And conveniently, you can remember these using the basic A, B, C, D. So A for ACE inhibitors, B for beta blockers, C for calcium channel blockers, and D for diuretics.
Isn't it funny how you can always break things down to A, B, C, D regardless
Everything fits into A, B, C, D. And this is the key table to try and remember. Okay. So basically, if the patient is younger than 55 years old and not black in ethnicity, then you can start with an ACE inhibitor or a beta blocker. The beta blocker is that it has a star by it, but I'll talk a little bit about why that is in a minute. If the patient is older than 55 years of age or is of black ethnicity, then you start with either a calcium channel blocker or a diuretic. Now, if either of these fail, so if your initial drug fails to control the hypertension, then you can consider additive therapy. So you add, say if you started with an ACE inhibitor, you can then add a calcium channel blocker or a diuretic, or indeed you can actually use all 4 or all 3 agents. Finally, in the setting of resistant hypertension, so if you've used all the agents and you're still failing to get a grip over the patient's hypertension, you can consider using alpha blockers, spironolactone, or indeed some other stronger diuretics. What it is important to mention, however, is beta blockers. So that's the B of your A, B, C, D. Beta blockers have largely gone out of fashion in the treatment of hypertension, except perhaps in the situation of symptomatic ischemic heart disease, where you might want to use them. But they've gone out of fashion basically because they've been shown to induce more new onset diabetes compared with other therapies. And this is particularly applicable to beta blockers, but can also occur with diuretics, particularly thiazide type diuretics. Right. So it's important to bear that in mind.
Okay, and I think overriding all of these the principles is the idea that it's the reduction in the blood pressure which is important here, regardless of the actual drug use. And this is a principle from the All-Hat study. And just to give you an example of that, you can follow the guidelines for the blood pressure using the ABCD guidelines. But there may be situations when, for example, a patient may already be treated with a blood pressure, as you already mentioned, if they're in heart failure or rate controlling someone in AF. And if that helps normalize their blood pressure, then that's fine. So for each individual patient, of course, as a result of other comorbidities, the optimal drug might be different to someone else who hasn't got the same comorbidities.
So often you'll find that certain patients get certain antihypertensives. For example, diabetics, say with any renal impairment, whether they're over 55 or not, will often be started on an ACE inhibitor.
That's right.
Because it has beneficial effects both to their hypertension and other pathologies and coexistent
cardiovascular risk. Okay. So to summarize, we've gone through the definition of hypertension and the broad underlying figure which you want to remember is a systolic of 140 and a diastolic of 90, and that's what you're aiming for. The classification and how you can break it down into primary idiopathic hypertension, also called essential hypertension, and that's the vast majority of cases, or secondary hypertension, which can be as a result of renal disease or endocrine disease. And then associated pathologies, so the consequences of untreated hypertension, for example, atherosclerotic disease or cerebral hemorrhage or retinal or renal disease. And this is really the reason why we're so keen to make sure that hypertension is treated.
And then finally, we looked a little bit at how you treat hypertension.
That's right, yes.
So particularly the ABCD treatment regime based upon age and ethnicity.
That's right.
Okay, so that completes this podcast. Thanks for listening, and we'll see you soon.
Thank you very much.